Hello and welcome to today's webinar, Changing Practice, How to Understand and Address Social Factors That Shape Child Health. My name is Deborah Garneau. I am the Title V Children and Youth with Special Needs Director in the Rhode Island Department of Health, the co-director of the Rhode Island Health Equity Institute, and a member of the National Center for Medical Home Implementation Project Advisory Committee. This webinar is the third and final installment of the 2016 webinar series titled Thinking Outside the Box, How to Advance Health Equity and Care Quality in the Pediatric Medical Home. This webinar series is presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau of the Health Resources and Services Administration. Before our faculty begin, I'd like to inform you of some housekeeping items. The slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the left-hand side of the screen. These questions will be answered at the end of the presentation. If we do not have time to answer your questions during the webinar, we will send you an answer directly via email at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website approximately 1 week after this presentation. After the webinar, you will also receive an email with a link to the webinar evaluation. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. Today's presenters have no financial or conflict of interest disclosures to announce. Today's webinar has 3 learning objectives, including the following. Describe the importance and prevalence of social factors in impacting child health. Describe the role of the pediatric medical home in identifying and addressing the social factors affecting child health outcomes. Discuss tools and strategies that can assist pediatric medical homes with identifying and addressing social needs that affect children's health and development. And now I am honored to introduce you to today's first speaker, Ronique Shields. Ronique Shields is a board-certified pediatrician who is currently the Chief Medical Officer and Vice President of Medical Affairs for Health Services for Children with Special Needs, Inc., a care coordination health plan focused on care management of children and young adults that qualify for Social Security income due to their categorization of children with complex medical needs. She is a past board chair and current board member of the DC Primary Care Association and active in the DC chapter of the American Academy of Pediatrics, serving as their medical home asthma champion. Dr. Shields has presented at national forums around creating a medical home for children in foster care, asthma, mobile health care delivery, toxic stress, culturally competent care, patient-centered medical home, and quality improvement initiatives. Dr. Shields?
Yes, good afternoon or good morning to those on Central Time. It's a pleasure for me to be here, and I thank Deb for that introduction. My goal this afternoon or morning is to look at and assist you all with identifying current social factors that impact child health and how we as providers, whether it is physicians, nurses, community health workers, social workers, anyone that may touch a child's life, be conscious and aware of factors that may impact their overall health outcomes. So, the next slide says social factors impacting child health. The social determinants of health are the circumstances in which people are born, where they grow up, where they live, where they work, their age, as well as systems put in place to deal with illness. And in turn, these circumstances are shaped by a wider set of forces, the economics, social policies, and politics. So when you think about this, imagine a child at the center of a bullseye, and that child is impacted by their home environment. Their home environment then is impacted by the community or the neighborhood in which they live, which then, as you go farther out from that bullseye, there's other forces impacting that child's well-being. When we think about social policies and politics, let's think about the Supplemental Nutrition Assistance Program, which helps in terms of providing services, food for children who may not have ready access to food resources, or the Temporary Assistance for Needy Families, which allows individuals to get access to medical services, home or housing because of their socioeconomic status. And we all know of the Affordable Care Act. So those are things when we think about politics and social policies, how they impact social factors in the life of a child. Then when you think about the environment where they live, imagine a child who may not be living close to an urgent care or not close to a primary care provider. So their only source of usual care is the emergency room, which then causes episodic care versus preventative well child care. Or they may not be close to a hospital. And so we think about the built and physical environment as things that surround a child that oftentimes impact access to and overall health care. The next slide is just a schematic of what I was just discussing. And if you look at health, look at all the different social factors impacting a child's health. And when you think about social connectedness, the first thing I think about is there a support system for that caregiver who has a chronically ill child. Imagine the picture of a parent, whether it be a father, whether it be the mother, or nowadays I'm encountering more and more grandparents or extended families who are caring for children. And if those individuals don't have a support network, it puts stress on them and ultimately stress on the child, which then can lead to poor health outcomes. So social connectedness is a big component of social factors that impact the well-being of a child. I also think about the American Academy of Pediatrics and how there is a campaign around identifying toxic stress at a very early age, because we all know that stress itself, there can be good stress, there can be neutral stress, and there can be toxic stress. Good stress are things like if you're a baby, you're crying because you're hungry, that's stress, but you can get fed. It allows that child to understand that there's a nurturing environment, that when there's a need, it will be met. Then there's neutral stress, stress that we all will encounter, which will neither be good or bad, but for the brief time that we're encountering it, it's stressful, whether it be loss of a loved one or perhaps maybe something happens in school. Then there's toxic stress, things that will have long-lasting impact on a child who then becomes an adolescent, a young adult. And we're looking at things like hunger. We're looking at things, food insecurity, housing, family dynamics. Those are things that are considered toxic stress that may impact the development of a child. So when we're looking at a child, a youth, adolescent, or even an adult, we think of things that they've experienced in their childhood that has a trajectory experience years later. So the next slide then continues to look at what we consider social determinants of health. And the listing here, we have availability of resources to meet your daily needs, safe housing, local food markets, access to educational, economic, and job opportunities, access to health care services, the quality of education that an individual may receive, and if then after graduating, if they're able to go on to another institution of education, or if they're choosing to do job training, the quality of the job training, the quality of the education that they're getting. Also social determinants may involve availability of community-based resources in support of community living, opportunities for recreational and leisure time activities, transportation options, public safety. All those are things that we should be thinking about when we encounter an individual in our practice, in whatever setting it is that we are in. Realize that there are many different factors that are impacting that individual that allows them to come to us in that one moment in time, whether it's a preventative visit, whether it's an urgent care emergency visit, whether they're in the hospital. Realize there's multiple factors that impact where they are at that time. The next slide continues to discuss other social determinants of health. The social support, like I mentioned earlier, which is looking at social connectedness and the ability for a caregiver to find support networks so that they can deal with a chronically ill child or even acutely ill child. Imagine a parent who cannot take off from work during the day, so they end up going to the emergency room or urgent care for services. And then the pediatrician or family doc is saying, well, this person is misusing the emergency room. They're abusing the emergency room. When in reality, this caregiver may not have the social support to care for other children or take off from work, so they tend to have to use the emergency room or urgent care as their source of acute care for that child. The other spectrum is that individual in a family where mom and dad may be working, the child's in school, everyone looks great, it's a nuclear-looking family, but yet they are also using the urgent care for episodic care versus going to the primary care. The reason they're using it may be different than the other scenario where the mom is using urgent care or emergency room out of necessity, whereas this other family, the one that you may think may have high health literacy or may know how to navigate the health system a little bit better, they're using it for convenience factor. Oh, we don't have to make an appointment. We can go to urgent care. Both entities, both different socioeconomic status, both different dynamics in their home using urgent care emergency room for different reasons. Other social determinants of health include exposure to crime, violence, and social disorder, presence of trash and lack of cooperation in the community, concentrated poverty and the stressful conditions that accompany it. When we talk about concentrated poverty, we're looking at generation upon generation of families living in poor, segregated parts of the community where there isn't an out. And that's concentrated poverty, where it tends to stay in the same geographical area and stay within generations of families. Language and literacy, when individuals come from other countries and may not adopt English as well as we expect them to, and so they're still using their primary language as a form of communication, that may cause bias on behalf of the provider. It may cause extended visits because we have to get an interpreter. But we have to be conscious of our own biases when we are dealing with individuals where English may not be their first language, or they may be hearing impaired. So there's many things that we have to think about that impact the health outcome of a child or person that comes before us when we are providers in the healthcare community. And now, 20 years ago, we didn't have to deal with mass media and emergency technology, technical things coming out, cell phones, internet, social media. Those things are keeping us sedentary. We have children now who have worse health outcomes than their parents versus 30 years ago. The children now who are dealing with obesity, diabetes, hypertension, have a poorer life expectancy, poorer health outcomes than their parents. And oftentimes it's due to the sedentary component of the social construct that we are in. And then obviously culture. I know one of the webinars discussed cultural competency, so I won't belabor that point. But being aware that we live in a society where many different cultures are in one particular area, and so being aware of the differences and your own biases is usually the first step to addressing cultural competency. Next slide, please. So what do we know? What exactly? We know that poverty limits access to healthy food and safe neighborhoods, and that is a
I'm sorry, Roni. I think one of the speakers must have pressed hold. Can the speakers make sure that they are not on hold? Thank you.
Great, thank you. So we know that poverty limits access to healthy foods, safe neighborhoods, and more education. And more education is a predictor of better health. We also know that differences in health are striking in communities with poor social determinants of health, such as unstable housing, low income, unsafe neighborhoods, or substandard education. By applying what we know about social determinants of health, we can not only improve individual and population health, but also advance health equity, which is what we're going for. If we look at Healthy People 2020, they highlight the importance of addressing social determinants of health by including one particular overarching goal, which is to create social and physical environments that promote good health for all. That is a very big goal. They've got 4 goals in the Healthy People 2020. First one is attaining high quality, longer lives free of preventable disease, disability, injury, and premature death. The second one is achieving health equity, eliminating disparities, and improve health of all groups. We just touched on the social and physical environment. And then the fourth goal is promoting quality of life, healthy development, and healthy behaviors across life stages. So when we think about the Healthy People 2020 overarching goals, we can put in social determinants of health under each goal and see how it impacts the outcome. The next slide is looking at physical determinants of health, the natural environment that an individual lives in, the built environment, the work site, schools, recreational settings, housing and community design, exposure to toxic substances and other physical hazards, physical barriers, especially for people with disabilities, and aesthetic elements, which goes to natural environment. Right now, I think about Texas and what's going on with the floods in Texas and how that is impacting the health. Imagine someone who may need to go to the doctor and unable to get to the doctor because of flooding. When you think of school environment, you may think of certain schools may have mold, may have asbestos. Not all schools may be peanut-free or allergy-sensitive. So you may have children who may have really bad allergies sitting with their triggers in schools and missing school frequently because they're having asthma attacks or having allergic reactions. So one thing I want us to understand is not only are there social components that determine health outcomes, there are physical built environment components that impact the health of a child, which they are in every single day. Imagine a child who's living in a home that may have mold and mildew, and they have asthma as a diagnosis, and they keep coming to you as a clinician or coming to you in whatever field that you are in, having an asthma attack with poor outcomes, having to go to the emergency room, and then you're thinking they're not taking care of themselves. When in reality, it's the environment that they're in that's triggering their health situation. The other thing I think about are individuals who may not be living in mold and mildew environments, but may have pets and don't want to get rid of their pets. Or they may be living with someone who smokes. Or they may be going to school and the teacher smokes or the teacher has pets. And those are environmental triggers for for a child who may have asthma who then ends up having to use the emergency room or urgent care because they're having an asthma attack. So again, when we're looking at the child, when we're looking at when they're coming to us, whether it's an acute episodic visit or it's a routine interaction for social services or preventative care, we have to ask these questions, because if you don't ask those questions, you will not know, and you wouldn't serve the child or the family member the best that they can be served with us as care providers. So let's go to the next slide. Health disparities. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And the key thing here is preventable. The only thing in life that's not preventable is death or paying taxes. But health disparities are preventable. And what we're looking at here is how can we contribute so we lower the burden of health disparities that many of our families face. And that's the usual and the unusual suspect when you're thinking of health disparities. So one of the goals for this webinar was to look at social factors that impact individuals living in rural, urban, suburban America. So rather than breaking it down all three, I decided to choose one, and I chose rural America as my case in point to look at social factors that impact health outcomes. So the next slide starts out around rural America. You see a picture there. That's what we all think of when we think of rural America. There's many different schematics of rural America. But rural residents are more likely to experience some of the contributing social factors that impact health, such as poverty. The impact of these challenges can be compounded by barriers already present in rural America, such as access to public transportation, fewer choices to acquire healthy foods, decreased access to jobs, and so forth. So when I think about rural America and compare it to urban America, I think of what I did in my past life with the Children's Health Fund. The Children's Health Fund was started by Irvin Redlander, who's a pediatrician, and Paul Simon, singer-writer, in 1987. And they noticed in New York City that a lot of children were living in homeless shelters and didn't have access to usual preventative care. So what they were able to do is get their resources together and take an RV and turn it into doctors and dental offices on wheels. And to date, there's over 25 programs that they have throughout the nation in both rural and urban America to address the limitations of poverty. And one of the greatest limitations to access to health care is transportation. So what they do is they bring health care to the neighborhood. They bring health care to the family versus expecting the family to come 20, 30 miles to get services, or in the urban America where you have health professional shortage areas, expecting individuals to go use 3 buses and 2 trains to get to a doctor's office. They bring the doctor's office to the neighborhood, which ultimately has improved significantly the health outcomes of children and families and adolescents living in rural America as well as urban America. The next slide talks about other components that we see that are social factors in rural America. Income, low employment, poverty, educational attainment, and literacy levels. Literacy levels may be low if individuals have to drop out of school at an early age to go and find labor. Race and ethnicity, health literacy, which is very important across the board, and adequate community infrastructure, which can ensure public safety, allow access to media, and promote wellness. Those are all things that impact the health outcome for rural Americans. And when we think about it, imagine someone living where they don't have easy access to a provider. So what will happen is if someone has a chronic medical condition, it may delay visiting their providers for routine preventative care. So someone may have diabetes. Someone may have high blood pressure. Someone may have asthma. Those are all things that can be treated. But if you don't have easy access and there is no transportation, then those diseases tend to go to worsening and more severe degrees before you get access to care. Or that you end up using the emergency room or get hospitalized versus using primary care, preventive care. And not at the fault of the individual, but we see one thing that is a common theme, not only in rural America but urban America, the lack of access due to transportation, whether it is no transportation or multiple uses or multiple public transportation venues, multiple public transportation to get to where you need. So you can take 3 buses, 2 trains just to get to the doctor's office. Or, worst case scenario, using the ambulance for some very simple outpatient diagnoses, whether it be fever, whether it be GI. But you see there's very different pictures of decreased access to transportation. Whether you have no transportation or you're using multiple forms and it's taking you a long time, or you use the ambulance unnecessarily to get to the emergency room. So the next slide continues to talk about other components of factors, social factors that impact rural America. And I want to take a step back and just think about what's happening in Michigan with the lead. That's not rural America. That's the suburbs, that's urban America. The lead level, the water quality will impact learning, impact lifelong health of individuals who've been ingesting high amounts of lead in the water. Access to safe and healthy homes. More recently, we're seeing a surge of medical legal partnerships. And that's so important for historically disadvantaged populations, the medical legal partnership. And I will talk from the standpoint of someone who has asthma, who may be living in a housing situation where the landlord may not be tending to the environment. And a letter from the doctor may not make any changes occur in that living environment, but a letter from a lawyer will. And so we have to arm our families and caregivers with resources to help address their living environment, such that if they have conditions that are impacted by the living environment, we help them get those changes and we advocate for them. We talked about affordable transportation. It can impact both job access and healthcare access. If someone doesn't have a car or not have access to public transportation, they may not be able to secure a job or secure health insurance because they're not able to secure a job. So there's multiple levels that trickle from not having access to transportation. Access to healthy and affordable food. If you took a map and placed it over areas where there is food insecurity, I can guarantee you will see not only a similar map of poverty, but a similar map of obesity in the nation. Because when there's decreased access to healthy and affordable food, individuals tend to eat non-nutritious cheap foods, which then causes intake of high calories. You add the sedentary lifestyle, you add the built environment, which they may not be able to go out and walk and play in, then you have individuals who may be obese. So contrary to the fact that individuals may think food insecurity may lead to malnourishment, it does lead to malnourishment, but it leads to malnourishment and obese, overweight individuals. And then obviously access to healthcare services. Rural America is also considered a health professional shortage area. The next slide talks about poverty rates. And the big theme here that I want you all to get is to see the poverty rates in rural America exceed those from the nation as a whole, and then you look at the elderly and the child poverty rate. So we know rural America is definitely at a disadvantage, as well as with income disparities, which the next slide addresses. The one thing I did mention, which the next slide talks about, is food insecurity. According to the USDA Economic Research Service report, household family security in the United States in 2014, 17% of rural households are food insecure compared to 14% for the nation as a whole. And then you see it more with children, households with children are impacted even more, with close to 24% of rural households with children being food insecure compared to 19% overall. The next slide talks about discrimination. And discrimination can happen on multiple levels. Many rural minorities may face discrimination and racism that can result in stress, negatively impacting their health. More troubling, unfair treatment may impact rural minorities' ability to fully access service to support their health, including access to health care services. And one of the things that I'm sure many of you are familiar with, or one of the entities, is we now have federally qualified health centers. And federally qualified health centers not only exist in urban but rural America to address access to health care and not looking at ability to pay as a barrier to access to health care. And we also have migrant clinics that are being established so that we look at those seasonal workers in different agricultural areas in the nation. So with rural America, and again, I will say rural, but think urban America, there are federal campaigns to try to address access to health. But discrimination is more than just racial discrimination. It can result in mental health impacts, including stress, anxiety, and depression. So imagine if a caregiver is stressed, anxious, or depressed, that will impact the health outcome of the child they're taking care of. Violence can be a result of discrimination, including intimate partner violence from stress, raised blood pressure, poor self-related health, chronic health conditions. Oftentimes, when there's discrimination and individuals feel that, they tend not to go to areas where or get resources that normally they would get had they not felt discriminated against. So a lot of their conditions tend to go the more longer, more severe and extreme. And you'll see one of the last statements I put is delay or failure to seek treatment, including preventative care, which can then lead to more use of the hospital, emergency room, and urgent care. And then last but not least is substance abuse. It's something that we can see as an impact of discrimination. Cultural beliefs is another component that impacts health outcomes. It may result in the patient experience that includes patients not following healthcare providers' advice and instructions, reluctance to use the healthcare system, and an experience of alienation, fear, and disrespect. If I feel any point someone may be alienating me because of my cultural background, or I fear what they may be thinking of me, or I fear what they may prescribe, or I sense a level of disrespect, I'm not going to go there for care. So again, this goes to, I think one of the webinars talk about cultural competence and the bias that we bring to the table, and being aware of those biases and trying to address them before we encounter patients. One thing I remember here in our health plan, we were doing some work around asthma, and we had individuals going into the home looking at particular triggers. And this one family had a whole lot of kittens and cats, and that was one of the triggers for the children who had asthma. And it was recommended that, it's probably best to get rid or isolate the kitten or cat from the child. And so they go back a couple months later, and they have more kittens, more cats. And the question is, well, why? Are they not adhering to the recommendation of the doctor or the nurse or the social worker around triggers in the home? Well, once we delved a little bit deeper, we realized that the kittens and the cats were killing the mice and the rats. And they were selling these kittens to other individuals in the housing unit so that they, number one, can get a source of income, but two, they're addressing the infiltration of these rats and mice in the area. So rather than making a assumption about their willingness to address a trigger for their child's asthma, we have to dig a little bit deeper to find out why they continue to have kittens in the home. And that's just an example of understanding the social construct in which our members live on a day-to-day, or not our members, our patients live on a day-to-day basis. Next slide. So what I will do is go through a case study. And what I want you all to think, based on the information that I just went over, I want you to think about social factors that may impact the health outcome of this particular patient. So AB is a 15-year-old ex-30-week preemie born to a teenage mother. Presents to your office at 3 p.m. with a complaint of difficulty breathing. The medical history, he's ex-30-week preemie, he has developmental delay, asthma, obesity. Social history, he lives with mom and paternal grandmother in a one-bedroom apartment on the 12th floor. Family's at risk of eviction due to mom being in between jobs. He's currently in 8th grade in special education at school, but doesn't attend school regularly. He doesn't know his father. The family receives food stamps. Family doesn't have a car, and there's no public transportation. So when you look at this 15-year-old, let's go back. When we look at this 15-year-old, let's in our head think of things that we normally would think when they come into the office. Let's say the office closes at 4. Number one, he comes in at 3 p.m., and you're thinking, why in heaven's name, if you've been having difficulty breathing, you're coming in at 3 p.m. versus 12 noon? What may have caused AB to wait until 3 to come in for his respiratory distress? Then we know he's an ex-preemie, has developmental delay. Now, look at this. He lives with his mom and the father's mother in a one-bedroom apartment on the 12th floor in an apartment building. So you have a unique construct of the family unit, which is mom, but not the mom's mom, but the father's mom. So you look at the dynamics there. They live on the 12th floor of an apartment building, and the family's at risk of eviction, so there's housing insecurity there. So the question could be, what is he doing, or what would they do if they're evicted? He's in 8th grade, so he's a 15-year-old in 8th grade. He's in special education, but doesn't attend school regularly. What does that look like in terms of the trajectory for his educational career? He doesn't know his father, so the only source of support is mom and the paternal grandmother, and the question we have there is social connectedness. How much support do they have, and do they give AB? Because based on this, it looks like this is a family at risk. They receive food stamps, the family doesn't have a car, and there is no public transportation. So the question is, maybe he did want to come at noon or 11, but he couldn't find a ride. He couldn't get there. Maybe he walked. Maybe, he had to get money to get a cab. So there's many different things you have to think about when you quickly may prejudge why an individual is coming in or why they are how they are. Next slide, please. So here now we have AB. We learn a little bit more about AB. He smokes weed sometimes to alleviate his stress. He's sexually active with his on and off girlfriend. They sometimes use condoms. He spent some time in foster care due to neglect allegations. His medications are albuterol, Flovent. He says he only takes them when he feels he has to. No known drug allergies, surgeries, bilateral inguinal hernia repair as an infant. And his vitals are 135 over 85, temp is fine, and he's clearly overweight, hypertensive, but we can't say hypertensive because that's one reading in time, so high blood pressure. So now we look and find out a little bit more about AB. he's smoking weed? Do we know if he smokes, if he's using other drugs outside of marijuana? He's sexually active but is high risk because, number one, they use a condom sometimes. His girlfriend is on and off. So the question is if he is just having sexual relations with her or she just having sexual relationships with him. If not, they're both high risk for multiple reasons, not only sexually transmitted infections, but also repeating the cycle of teen pregnancy. Then we go to his medical issues. He has asthma. But look here, he only takes his medicine when he feels he has to. We've got a rescue medicine and a controller or preventative medicine. Clearly there needs to be some education of what may be triggering his asthma attacks. Could the smoking trigger? He's not taking his medications appropriately, which may cause him to have to go to the emergency room or be hospitalized because of his asthma. And then clearly he's overweight and has high blood pressure. So what social factors can contribute to his overall health outcomes? The next slide. I just put a couple there because I want you all to think based on what was just discussed prior to this case study, things that in your setting, if you take AB and put him in rural America, minus the 12th floor apartment building, in rural America, or take AB and put him in the suburbs or put him in urban America, how can we address his needs differently based on where you're coming from? So let's look at things that may impact his health outcomes. We've got teenage parents. We've got him smoking marijuana. We have sexual activity, unprotected sex. I just listed 3, but I did this on purpose so that you all can go back and start to jot down things because it's a very rich case for social factors that impact health outcomes. Asthma is not preventable, but asthma visits to the emergency room and hospitalization is if it's well controlled. And so what can we do for AB to, number one, address some of the social factors that impact and his health such that he can have better outcomes socially but also better outcomes from a health perspective. So the way we look at that is from a patient-centered medical home perspective. We're looking at the patient-centered medical home, how we're looking at the urgent medical needs, disease management, care coordination, wellness, all of this focusing on AB. So next slide. The medical home is not a physical place or a building like a house or a hospital or a clinic or an office. It's not a physician who makes house calls. It's not a recognition or accreditation or certification in and of itself, but it's how care is provided, the attitude that we have as healthcare providers when we're dealing with patients. Next slide. I want to make sure we have time for Dr. Tizanu, so I'm going to just speed this up really quick. So what can we do? We can assist in the development of posters and other information materials about the medical home, assist in eliciting feedback from other families, help to plan advisory councils, and initiate PDSA cycles, trying to figure out what is best for your unique setting. Next slide, please. So what I'll do is hold off on the promising practice. If I don't get to these, it can actually be found on the NCHMI website. So I will stop now because I want Dr. Tizanu to give her case study or case vignette, and then if we get an opportunity to, we will discuss some of the promising practices.
Thank you, Dr. Shields. It's now my pleasure to introduce our second speaker, Abila Tizanu. Abila Tizanu is the founder and executive director of the One World Center for Autism. She is a general pediatrician who, prior to her current position, worked as a clinical associate at Children's National Medical Center in Washington, D.C., providing school-based health care for children with special needs. A native of Washington, D.C., raised by parents who immigrated from West Africa and the Caribbean, she now resides in Laurel, Maryland, with her husband and 5 children. Dr. Tazanu is an advocate of family support, community awareness, and comprehensive medical and therapeutic interventions for children and youth with special health care needs and their families.
Thank you, Deborah, and thanks, Dr. Shields, for having me be a part of this webinar. I'm going to present a case that's very close to my heart to have you see how social determinants can actually work in a different way. So if you can advance to the next slide. Okay, so this case study is about an African-American mother. She, like myself, is of West Indian and West African origin, residing in a middle-class suburb, have access to good health insurance, private health insurance. But at around 21 months of age of her daughter, she had some concerns about her child's development, and she took her to her pediatrician with these concerns. Next slide. Basically, her concern was that since the birth of her younger brother, she started showing regression, primarily in the areas of communication. She appeared to still be pretty friendly, but just seemed to be more aloof. And at the time of raising these concerns, she was advised that, children will regress at the time of the birth of a younger sibling, and that she really shouldn't worry. So she went home and continued to try to kind of live life as usual. Next slide, please. She continued to watch, and at the 24-month well child check, she again raised concerns about the fact that her daughter, while she continued to appear happy, started to become unresponsive to her needs and really seemed to be living in a world of her own. During that period of waiting, she reviewed information on child development that she had acquired at the local library and really started to have some very deep-seated concerns. Again, she was reassured that her daughter Cora would grow out of the stage and not to worry. Next slide. So she leaves her primary care office feeling pretty ambivalent about what to do. She decided that she'd just keep watching and giving her daughters opportunity to learn and grow in their community with other children. But she soon found that these social outings became very difficult for Cora, as she seemed to have very little interest in other children, and then also began developing very difficult behaviors in loud and bright environments. She also started demonstrating challenges with directions and concepts that she seemed to know prior, like numbers and letters. Next slide. Finally, after about 6 more months of watching her child's development, she decided to call the number for an early intervention in her state while watching a children's television program. Shortly before her 3rd birthday, right around the time of her 3rd birthday, she was evaluated by a child find team and then diagnosed with autism by a school psychologist. At that time, they had a change in insurance, so private insurance, and her new primary medical provider was kind of brought to speed with the developmental concerns and encouraged an autism evaluation by a medical team. Next slide. So this case is a little bit different than the one that Dr. Shields presented because the social factors are probably very opposite. Here you have a middle-class mother. So finances aren't necessarily a challenge, residing in a suburban neighborhood with access to care and access to good insurance. And then you also have a mom who has the educational ability to obtain information on child development and to understand that she is appreciating the difference between her child's development and her other children as well as children in her community. In terms of the clinicians working with her child in that child's pediatric medical home, I think the social factors really didn't have them considering things that may factor into this child's development. And actually maybe that education level could have played against her in that she was thought to just kind of be a worrying parent. And so her concerns at the initial time of her presentation at 21 months and then again at 24 months I would say were somewhat dismissed. If the provider had used objectives, like an objective tool, that may have helped, but primarily they were residing on kind of subjective knowledge and reassurance to have the mom wait for about a 9-month period, watching wait. Next slide. Some possible things that the provider could have done to kind of just think and kind of close the gap, no matter what the social circumstances may have been, would have been to use some kind of developmental screening, really just take heart to what that parent was saying and provide referrals to early intervention and to a developmental pediatrician that was readily available given where this mother resided. Our next slide. Okay, so some take-home messages about this particular case study was that every patient, every family, every clinician brings a unique perspective, and so we have to consider that in how we evaluate and treat the children that are in our care. And that culture extends beyond race and ethnicity. We have culture just around our various communities, no matter where we come from. But we should consider social factors that may impact health and well-being of all patients and families, not only just looking at those social factors that we all know to be challenging social factors, but maybe even social factors that are not considered to be as challenging, but may play into that child's access and evaluation. And lastly, the pediatric medical home can play a key role in identifying and addressing social factors that impact a child's health. And I said earlier that this case is very dear to my heart because it really is my story. It's the story of my daughter, my first of 3 children who were diagnosed with autism. So just really taking a different spin on how social determinants can affect how we view our patients, how we evaluate them, and how we address concerns that parents and caregivers bring to us. So I will turn this back over to Dr. Shields and have her kind of conclude. Or Deborah.
Okay, thank you very much for that presentation. Before we move on to take some audience questions or perhaps go back to the promising practices that Dr. Shields skipped over, I wanted to share some valuable resources that are available to help with understanding and addressing social factors that impact child health. So the first is the National Center for Medical Home Implementation, and there's several links that will be available to you here. The National Center for Cultural Competence, National Center for Family Professional Partnerships, Family-to-Family Health Information Centers, and the state Title V programs, so accessing the Title V programs. So, okay, I think since we just have a few minutes left, then we'll just proceed with the closing comments. So thank you so much for your participation, and for hearing the both of our speakers today and the case studies challenging us and setting our minds to focus in possibly a different way as we interact with our families that we're connecting with. And we thank our faculty members. We appreciate your time sharing your experiences and your expertise with us. This webinar recording, slides, and unanswered questions, if you have any, put them in the chat box, will be archived about a week from today on the National Center for Medical Home Implementation website. Additionally, you will receive an email after this webinar shortly. We will be asking you to complete an evaluation, which will only take a few minutes of your time. We would greatly appreciate it so we can get your feedback. The National Center for Medical Home Implementation houses a number of pediatric medical home implementation resources on their website. Visit the links on your screen for more information, and do not hesitate to contact the National Center for Individual Technical Assistance using the contact information displayed on your screen. This has been the third and final installment of our 2016 webinar series entitled Thinking Outside the Box, How to Advance Health Equity and Care Quality in the Pediatric Medical Home. Thank you all very much for your participation.